Good morning. Thank you for having me here. I'm delighted to be here. It's a great meeting. During the next few minutes, I'd like to tell you what we're doing in an attempt to develop a treatment planning method for focal therapy that would be widely applicable. Tracking prostate biopsy is one of the two values of the contemporary biopsy method. We only talk about targeting, but we believe that tracking prostate biopsy may be sort of the unsung hero of current biopsy methods. It's underutilized, should be used further, and we are using it, we think, effectively now to help develop a planning method for focal therapy, tracking biopsy. I speak to you from a rather large experience with MRI-guided biopsies, which we started in 2009. We've done over 4,000 procedures in nearly 3,000 individual patients, and all of our work has been done with the Artemis device, which was the first FDA-approved device, and which is the one that I stumbled across at the 2008 AUA meeting, and so that's been what we've used. Again, everybody understands, let's go back one here. Everybody appreciates that targeted prostate biopsy is valuable. It helps raises our yield tremendously. But we've got all these other biopsy site locations that are recorded in an image fusion device that are available for study and for consideration in terms of planning focal therapy. We got interested in this early on. This is actually our first publication on this subject, where we did a little study where we took men who had biopsies. Their biopsies were shown in blue. We then took out the probe, asked them to walk around, reinserted the probe, and then tried to determine if we could go back to the original site or not. And we found that we could go back to the original site within a few millimeters, very accurate. Based on that early study, we then collaborated with investigators at the University of Michigan, Scott Tomlin's group, Ganesh Palapatu, and determined using molecular markers that we could actually resample the original clone of tumor over time. So targeted biopsy and tracking biopsy has a great value to us, and we use it routinely in all our patients. All our patients have a systematic 12-core biopsy initially, along with a targeted biopsy. We use systematic biopsies less often subsequently, but we always do it at least once in every patient, and we can resample the same clone of tumor. In about 96% of the cases, we determine that using ERG and TMPRSS2 concordance. So can we use these biopsy sites to guide focal therapy, the recorded spatial locations of these biopsy sites? What I'm going to show you is kind of a light version of what Shyam Natarajan, my colleague, is going to show you this afternoon, where we actually employed over 60,000 biopsy site locations to develop sort of an artificial intelligence or machine learning algorithm to help plan even more carefully. We know that MRI underestimates tumor geometry. My engineering colleague, Alan Priester, who's at this meeting, showed in some elegant research that if this is the tumor seen in green here, that the seen on ultrasound, rather on MRI, this is what the MRI sees in green. The actual tumor is in red, and we look at a large number of these tumors. The actual underestimation of tumor diameter was about 11 millimeters, and the underestimation of tumor volume is 3x. So the MRI is not adequate to help us plan focal therapy. We need more. If we're going to use a uniform margin to go around the tumor and try to encompass all of the tumor with uniform margins, we would need this graphic here. This chart shows the distance beyond the region of interest here on the ROI here, and the chances of encompassing all of the tumor here. And he's shown the point here to be the 50%. In other words, if you go out 13.5 millimeters uniformly around all the margins of the tumor on MRI, you're going to get 50% of that tumor encapsulated. To get 80 or 90%, you got to go out to around 20 or 30 millimeters of space around the tumor. So a uniform margin is problematic in terms of planning focal therapy, because everybody knows these tumors grow in fingers, and they're unpredictable, and they're not visible on MRI. We then took a group of 39 men who were ideal candidates for focal therapy. They fulfilled all of the criteria and studied their prostates. These men all underwent radical prostatectomy. So 39 great candidates for focal therapy who all had radical prostatectomy. And we tried to determine what kind of a shape, what kind of a volume enclosure would be necessary to treat these patients. And we determined, Dr. Priester and his colleagues in engineering determined that a paraboloid is the shape that should be used to encompass all of the tumor in a manner that could be widely applied. A paraboloid, if you don't know, as I didn't before, is the shape of a rainbow when you looked in 2 dimensions, and a shape of a satellite dish when looked at in 3 dimensions. Here's an example of applying the paraboloidal margin to a tumor, MRI visible tumor in green, actual tumor in red, and the paraboloid overlying that tumor. And we've applied that with one proviso, and the proviso is that we know where our biopsy sites are located in relation to that paraboloid. For example, if a blue dot here shows a negative biopsy site, we could contract the margins safely in that area. And on the other hand, if that individual has a tumor extending beyond the paraboloid, well, we're going to expand that margin and customize these treatment sites. And that's how we've been doing our work. Here's an example. And all of this was done using HIFU, because it's easy to transpose the targeted biopsy information into the HIFU device. So here's an example of how we use it. This is a MRI visible lesion in green again here. The paraboloid is shown in yellow overlying that area. The skittles from the HIFU treatment plane are shown here. And when we, another example of customizing the paraboloid, I'll tell you, in HIFU, we have been very cautious about treating the urethra. We did the clinical trial that got HIFU approved, and it were for radio-recurrent prostate cancers. We went across the urethra in these patients. It was a highly morbid procedure. We try to avoid that if we can. And so let's go back. We pull back the margin as much as we can to avoid the urethra. The paraboloid can be customized. And when we did this, and this is a small group of patients, this is just enough to give us encouragement to go forward, we found that if we stuck to the treatment outline strictly as defined in the paraboloid, that we could get about an 83% no cancer rate when we rebiopsy these patients 6 months later, as we have done in all of our patients, treating a volume of about 22% of the prostate. When we cheated on the paraboloid and tried to contract the margin somewhat, we found that our success rate wasn't quite as high. In conclusion, that we'd like to point out that targeting and tracking of biopsy site locations we think are both important, underutilized. Encourage you to use them, tracking biopsy sites more. Tracking biopsy sites can be used to create a treatment plan for focal therapy, and a paraboloidal treatment outline allows accurate lesion ablation with the least amount of collateral damage. I'm here by virtue of the work that a lot of my support staff has done, especially thankful to our close relationship with the bioengineers. They're just in the building next door to us. We work together and see them all the time. Thanks for having me.